Cornwall students know me, and the rest of you we've met when we've done some other webinars together for clinical skills. So Caroline Jameson, your module lead, has asked me to talk about respiratory assessment today. So we're focusing a little bit more on building on the skills that we do in clinical skills. I shall be pausing as we go along to look at the questions that you're typing in. Some people already started jotting a few things down. I'm going to start off with a poll, see how we all are today. And so the first thing I'm going to do is ask you how you all are today. So if you want to have a little click in, let's see what you're thinking. Well, at the moment, most of you are looking forward to the weekend, but a few more are coming in. Let's see how you go. Come on, let's start with a wake up. How are you doing? Okay, nearly 100% of you, and I'm going to share this. I find out where. Okay, close the poll. And I'm going to share the poll with you. Okay, I'm just going to try and adjust my microphone a little bit to see if some of you are having trouble without hearing. I'm going to plug in things a little bit. Some of you are having trouble hearing me. Just checking to see I haven't got any loose wires or anything. How is that? Are people still having problems hearing me? Bit crackly. Oh dear. Not a good start. What I can try and bit muffled. What I'm going to try and do is I'm going to unplug my microphone. The PowerPoint and the presentation will be on the module site once it's been recorded. So I've unplugged and now I'm talking without the microphone. Is that any better? Thank you, Sean. Yeah, okay, I'm going to obviously speak a little louder. Fine. Right, looks like that's better for you. So I'll try and obviously, the other thing is I've got my webcam on at the moment and that does slow the streaming. So I'm going to wave to you and turn the webcam off. I'll turn it back on a little later. Okay. Yeah. It is a bit of an old headset as well. Right, so a bit of a mixed bag on the poll there. Quite a few are tired. It's the end of the week. Yes, I know you can't see me. I've turned the webcam off so it improves the streaming. If I have the webcam on, it slows it down. Okay, 26% of you are tired, 10% lethargic, 31% good, and 50% of you are looking forward to the weekend. I'm hoping that it's not going to be too onerous for you today. I know you've all been in study all week, so let's have a look at respiratory assessment. Just give me a second, and we'll start the presentation. She says. Okay. So thinking of where we have before, I'm just going to talk about what we think the what respiratory assessment's all about. Now I know you know these things. We're looking at respiratory state of the patient, but also undertaking respirations does provide us information about the cardiovascular and the neurological system. When people become unwell, breathing is usually the first vital sign to alter for when people are deteriorating. So it's one of those key things that we can do quite quickly, quite readily, by looking at somebody and give us an indication of how they're doing. What we do know is that breathing difficulties precedes adverse events with associated increase in mortality. In other words, it's an indicator of deterioration and death, potentially, from a serious problem. So we'll build on that as we go through. So we know it's really important. You've got to be able to undertake a respiratory assessment to be able to understand and interpret what you're seeing and what you're finding. So here's some terms for you. I know, Kevin, when we do clinical skills, it always has some terms for you. Some of these you may have heard before. Some of them may be new to you, but you will certainly hear or see written most of these again. So ventilation is about, in relation to, the capacity of your body to suck air in, as it were, so to ventilate, so to draw air into the lungs. Diffusion is about the capacity of oxygen to cross and carbon dioxide to exchange across the alveoli wall into the capillary network. Diffusion. Perfusion is about the uptake in the cardiovascular system and the transportation around the body. So perfusion into the sites where the gaseous exchange will take place again at the tissue level, at the cellular level. Respiratory drive, now we've talked about this before, and this is what makes us breathe and makes us breathe in response to what's happening within the body. Respiratory rate, you know that term. You know that term well. Now, some of these terms you will have come across either from us talking to you before, but also in your workbook for skills. They may even feature in your exam. I'm not promising they will or they will not. But I want to recap. Bradycardia, slow respiratory rate. Cyanosis, the colour of the skin or the mucous membranes caused by depletion of oxygen. Dyspnea, you'll hear that term used a lot. Difficult or laboured breathing. Hyperventilation, prolonged, deep, rapid ventilation. Hypo, so there's this hyper and hypo words that you're starting to become familiar with. Shallow and slow breathing. Hypoxia means inadequate level of oxygen in the cells, and hypoxemia is related to the blood. And you'll hear these terms used. Orthopnea is breathless unless the person is sitting upright. So we talk about orthopnea. If the person lays flat, they start to have difficulty breathing. And tachypnea we've talked about before, and that's rapid respiratory rate. These terms are used a lot when we're thinking about respiratory assessment and what we're describing. And as I said a way back, that you have to get a little bit of Greek and a bit of Latin inside you when you start looking at terminology. Okay, just pausing to have a look, see if anybody's put any additional questions in there, and we'll move on. So that's terminology. So, when do we undertake respiratory assessment? We've talked to you that it's part of the initial patient assessment for all vital signs, but it's then part of the ongoing monitoring that is required for patient's condition. So we decide, and when we've been working with you in skills, we've talked about how frequently you would decide to take somebody's vital signs. And if somebody has got altered breathing rate, then you would do that more frequently. So it's assessing and monitoring ongoing. Comparing any changes to baseline observations following an operation or an intervention, anaesthetic, which will influence respiratory rate. It might be part of monitoring when there are investigative procedures going on, as I said there, But say somebody's had fractured ribs, chest trauma, then you're certainly going to be monitoring their respiratory rate, or if there's an emergency deterioration. The other thing as well is when people are receiving intravenous fluids, blood transfusion or blood products, part of monitoring that you're not overloading them with fluid or that they're not having a reaction to blood or blood products. You need to carefully monitor frequently their respiratory rate. A little bit more. Evaluate the patient's response to interventions, and as I said, if they've had an anaesthetic, and certainly when we've gone through our workbooks, we've talked about opioids that will affect respiratory rate and can cause respiratory depression, so it's very important to monitor. When people are receiving oxygen therapy, it's really important to monitor their respiratory rate, otherwise you won't know how they are responding to the oxygen therapy. Bronchodilators are given, we'll talk a little bit more about some common respiratory disorders, but bronchodilators are given to, as an inhalant to open the air passages to resolve breathing issues, and so obviously you would want to see how they are responding. Progress and deterioration. If people have got long-term respiratory conditions, then you're going to monitor them, and there's a couple mentioned there, asthma and COPD, chronic obstructive pulmonary disease. I will talk a little bit about these a little later on. Okay. Are you all still able to hear me? Because a couple of people are still having problems. Yep, some of you are. Okay, I'm going to keep going. Yep, good. Okay. Okay, so when we talk about preparing patients for any intervention we're going to undertake, we talk to you about gaining consent, but certainly when we talk to you about undertaking respiratory rate, there is a bit of a problem, because if you say, can I just check how you're breathing, then people are conscious of their breathing and may not breathe. And we talk to you about strategies that you can use to pretend you're taking their pulse rate while counting the respiratory rate. But essentially you are going to gain consent for any interventions, but you can observe somebody's respiratory rate from the end of the bed or at the side of the bed, or if you're standing next to them. We've talked to you about those techniques. Essentially you want to know what respiratory rate is resting, so that they're sitting or laying in bed rested. If they've undertaken any physical activity, then obviously people are going to be breathing more rapidly, so it's not going to give you a true factor. Obviously, if somebody has taken some physical activity and they become severely breathless, then obviously you are going to record that and report that. But the ideal situation is that they are resting. The idea is that they should be sitting upright so that they have good lung expansion. A 45-degree or 60-degree angle. Our nice gentleman in the photograph there looks very comfortable, and that's about the right angle. Obviously you may be taking somebody's respirations if they're sitting in a chair, and they may well be more upright, but that's the kind of thing. Obviously, if we talked a minute or two ago about orthopnea, difficulty in breathing when laying flat, and you may well be measuring that. So if somebody's laying flat and having difficulty breathing, you might just check their respiratory rate and then sit them up and see what difference that makes. So you may be making comparisons. Those things are likely. So what we're going to do, we're going to consider a little bit more about what we're going to do when we're observing patients, and we've talked about already. So we're looking at the rate. But what we're also looking at is the depth of breathing. Is it shallow? Is it deep? Are they comfortably taking breaths? How regular it is? And then we're looking at the term work of breathing. what effort is it requiring for them to breathe? Is it a struggle? Are they using accessory muscles of ventilation? Accessory muscles of ventilation is the shoulder girdle. So if when they're breathing, they're raising their shoulder girdle. Okay. Now you're all sat there. If you take a breath in and raise your shoulders at the same time, you will actually have the sensation that more air is being pulled in. Yeah? The other thing that they may be doing is that they may well be leaning forward to assist breathing. The reason that is because when you and I are sitting breathing as we are, we're only filling up part of our lungs, just a quarter of our capacity will help us. But think about a mental picture in your head, 100 meters run in the Olympics. At the end of the race, the athletes, even the best, Usain Bolt, will still lean forward at the end. And what that does is expand the intercostal muscles to allow more depth of breathing, more air to be taken in. So if somebody is having difficulty breathing and they are leaning forward or are comfortable leaning forward on a table or sitting in a chair leaning forward, it is actually a physiological thing to enable more air to be drawn into the lung more easily. So, using accessory muscles, their position and their dyspnea, breathless. Now the other thing, a little picture here, when I put the presentation on, go and have a look at the YouTube because you'll see this visually. There are quite a lot of YouTube videos about shortness of breath. So the other one is pursed lips and nasal flaring. The reason why pursed lips will assist breathing is if you purse your lips on expiration, it will constrict the exit of the air you're breathing, therefore keeping air down in those air sacs for longer, prolonging the capacity for gaseous exchange. Now people don't sit and think, I'll purse my lips and it'll help my breathing. Again, it's a physiological response. So people with chronic lung diseases, you may see, I've talked about the position, the sitting forward, but pursing lips on expiration holds open the alveoli and the bronchioles longer to increase the potential for gaseous exchange. As I say, when you click on the YouTube video, you'll be able to see that clearly demonstrated. So those are things that you can look for, that you're looking at. So picking up, oops, sorry, I jumped forward too quickly. So picking up on dyspnea, it does require effort and energy. And gaseous exchange is never that good. And it could be the result of obstruction of airflow, which could be caused by infection. So you've got increased sputum collecting in the air passages, causing obstruction. But the other thing we talked about earlier, I'll talk about asthma later, is asthma is where you get bronchial constriction and you've got obstruction of airflow. The more effort that people have to put into breathing, the more difficult it becomes, and the more tired and exhausted they become. And this is when you start to have some warning signs, and you need to start to think about how important these things are, and how you need to consider reporting what's going on, monitoring. So a couple of other characteristics of breathing. So we've talked about when you're looking, are they breathing rapidly? Are they breathing shallowly? Is there inadequate ventilation? There's some terminology you may see written or talked about, and chain stoking is one of them, and it's named after the person who first described it. Irregular breathing pattern by periods of no breathing. This is often seen before death, where the respiratory centre is being depressed, raising carbon dioxide levels, and you'll see this. And you'll see people talk about it as patient is chain stoking. The likelihood of their death is going to be very imminent. The other one there, oops, sorry, trigger happy today, is Kussmaul's breathing or air hunger. Deep, rapid respirations. And this is linked to a rise in the respiratory acidosis. And this is ketoacidosis is where diabetics become severely unstable and there's high levels of ketones and it affects the respiratory rate. And again, it just may be something that you come across or you hear talked about. So we're still on look. Now we've talked about cyanosis with you before. The difference between central and peripheral. Peripheral is, as displayed in the picture, is the fingers and the toes. Some of you will be, certainly in skills but also out in practice, will be using oximeters. And if the skin discoloration is as on our picture there, then the chances of accuracy of your oximeter are going to be impaired. It will give you a low reading, but because of the coloration, deep coloration, so you always have to, when you're using any of these kind of measures, take into consideration it's a good ready reckoner oximeters, good ready reckoner, but when patients have severe respiratory problems, there are other things that need to be evaluated to give you a more accurate picture of what's going on. Central cyanosis, we've got our patient there with blue lips, but if you pull that lip forward, the inside of the mouth, the mucosa, would also be that dusky purpley colour. Maybe because of hypoxemia, lack of circulating oxygen, but the other thing is peripheral cyanosis might be to do with peripheral vasoconstriction. Now, peripheral vasoconstriction, think about wintertime, people becoming cold. How many of you have had blue cold fingers when it's been really cold? People with hypothermia. So again, you may find that. The other thing is if people have got peripheral vascular disease, so deterioration in their blood vessels, in their limbs, then again, it's not always going to be an indication of breathing. Now there's a little picture here of clubbed fingers. So convex bulbous end to the fingers. It is commonly associated with cardiac and respiratory problems. And what you do is you literally will see that in their fingers, but you would ask them to hold their fingers up and have a good look at them. There is no, I can't give you a physiological explanation as to why the fingers change in that shape, and about 15 to 20% of the population have clubbed fingers, not because they've got respiratory problems or cardiac problems. But it is, again, if people have got respiratory problems, it's an indicator that it's a chronic condition, and it's something that will be looked at. Aha, sputum. I don't know how many of you have been come across and had to deal with and explore and examine sputum. You can tell us if you want. You can stick your hand up if you want. I've always been a bit new about sputum, and then ended up working on respiratory wards. I'm not quite sure how that kind of worked out, but it's really important. Sorry, the sound is coming and going still for some of you. So the questions here are all about sputum. If somebody, expectorating means coughing up, you should observe. You can get a lot of information from sputum. So you're looking at the colour, the odour, the consistency and the amount. And here's some indications here
of what that means. So our first picture here, green, yellow or creamy sputum, indicator of infection, and this is why it is important to look at sputum and to continue to look at sputum, because if somebody has infected sputum, they are likely to require antibiotics, and you need to continue to look at it to see whether there's a change in colour or whether it's purulent means a lot, okay? So if it's purulent, there's a lot being produced, or if it's being reduced, or the colour's changing. If the colour's changing back to white sputum, then the infection is clearing, and if the amount is reduced, then it will be an indication that they're recovering. The next one, white, frothy or pink sputum, indication here. This is to do with pulmonary edema. This is to do where the interstitial fluid is seeping out of the blood vessels and increasing the space between the blood vessel and the alveoli and pours into the alveoli, and you can have white, frothy sputum and causing pulmonary edema. This means that somebody is extremely ill and needing urgent, immediate treatment, because they are literally drowning in their own sputum. This is to do with heart failure, the heart not working well, and urgent treatment to restore, to increase the heart productivity and to remove the fluid from the body needs to take place. So blood in sputum, frank blood, hemoptysis is the terminology. And this is important because it can be an indication of cancer, carcinoma, lung cancer. The other thing is pulmonary embolism, where you have an embolus blocking one of the micro capillaries surrounding the alveoli, and will rupture into the alveoli, and you may see a resulting blood being coughed up, and of course fractured ribs again. And damage to the lung tissue can also cause that. I'm not here today to talk about lung cancer, but there's a few pointers there, and such as that it is diagnostic. It's diagnostic that something serious is happening within the lung, because it means that the tumour is eroding into blood vessels. Because we have a great lung capacity and we can continue to function really well by not using our full lung capacity. With lung tumours, unfortunately, they're usually very large by the time patients notice debilitating symptoms of the breathing difficulties, and also a rupture into the blood vessel, and it's not a good sign. But anyway, that's I'll move on. Now the other thing is black specks in the sputum. So we've got a picture of what they look like under the microscope, and it can indicate cigarette smoking. It's the tar. Or if people have been in smoke inhalation. Okay, somebody's asking me if people can survive with one lung following surgery or injury and requirement for lung removal, and the answer is yes. Many years ago, and you will meet people because you're going to be meeting older people, would have had large parts of the lung removed, or even the whole lung removed for tumours. Tuberculosis, treatments for tuberculosis was to collapse the lung, but also to remove the lung. It's called a pneumonectomy, and people can survive. What you have to do is assess their lung function and their ability, how good the capacity of the other lung is. So the answer is that there. Coffee granule vomiting, okay, somebody's asked me about. So black specks in the sputum is, we've got a little picture of our green sputum there, and so you would see, it might be white or it might be green, but you'll see literally black specks. Coffee ground vomiting is coming from the stomach. So somebody's vomiting from the stomach, and it's because there's been a rupture of a blood vessel in the stomach. due to either a gastric ulcer that's eroded its way in through the wall of the stomach, or a tumour, again, eroding through the wall of the stomach. So coffee ground vomiting. You can get also coffee ground vomiting from prolonged vomiting, gastroenteritis as well. Why it's coffee ground is that the blood bleeds into the stomach, but the hydrochloric acid changes it black. And if you've seen coffee ground vomiting, it's got a lovely acidy, bloody smell to it. Once seen and smelt, never forgotten. Black specks in the sputum is literally called, it's black specks. With the blood, it's called hemoptysis. Hemoptysis, blood in the sputum. Okay. Again, I'll put this up and you can have a listen on YouTube to some sounds of the difficulty in laboured breathing. Some of you may have cared for patients with breathing problems, and what you need to do is you need to listen. When you're doing your respirations, you're doing all those things, but you're looking and you're listening. Can you actually hear the breathing? Can you actually hear that from standing beside somebody? Because if I stood beside you or anybody, I wouldn't normally hear their breathing. If you can hear, then there's an indicator there's a problem. If people have got bronchospasm in asthma, you can hear what's called a wheeze, and you will hear the air trying to squeeze through the narrowed air passages. And say, if you click on this link, you'll hear that. The other thing is, if people have got a lot of sputum, you will also hear air passing the sputum, and you can, what we call rattling. You can hear the rattling of the sputum as the air passes. Usually there'll be coughing as well, so you'll hear rattling and coughing. With pulmonary edema, you will hear the breath sounds, but you may also hear the gurgling of the fluid as it fills their lungs. There's quite a range of sounds that you could potentially hear. Now, what we don't necessarily teach you, but when you're working in respiratory areas, these things are quite important. You will usually see nurse specialists or doctors undertaking this part of a respiratory assessment. However, I also urge you that if you are going to be caring for meeting patients with breathing problems, ask them if you wouldn't mind if you put your hands on their chest to feel if their chest movement is symmetrical. In other words, both sides should be rising and falling at the same time. And you can do that visually, but also you may just put your hands on the lower part of their chest and you can feel, and you'll see physiotherapists do this as well. If somebody has a collapsed lung, say a pneumothorax, then you will only see and feel one side move. So as I say here, you can observe it or feel it. You're looking at the depth and the quality of the movement, and inspiration, expiration. So it just tells you there, anterior, that's at the front, thumb should be either side of the chest midline, and the remaining fingers are standing around the chest wall. You'll see diagrams of this. So when the patient breathes in, your thumbs should move apart. You'll observe doctors doing this when they do a respiratory assessment on patients, and I said and you get an opportunity yourself. So if there's problems with chest expansion, then there's going to be a reduced gases exchange. Unilateral, that's where I've just talked about. Single rising is about pneumothorax. It can also be where fluid has got in between the pleura that covers, there's two layers of pleura that cover the outside of the lung. And sometimes with a pneumonia, if a whole part of a lung is affected, you may see a reduced inflammation. The other thing is about restriction, I've not put it on here, is if somebody has got pleurisy, so that's inflammation of the pleura, where the pleura rub painfully together when somebody tries to breathe, it will prevent them from taking a proper breath. It will hurt, and so you may see a mismatch in its lung expansion. Just before I talk about adjuncts for assessment, and I've not listed on here, is obviously your stethoscope. We use stethoscopes to listen to the heart. You use stethoscopes to listen when you're taking blood pressure recordings, but listening to the chest through a stethoscope, again, you will see doctors, nurse specialists and physiotherapists doing this. If you get to work on a respiratory ward, please ask patients if they wouldn't mind you listening, if they've got chest conditions. If somebody's got a wheeze, if you listen to it through the stethoscope, it will be very amplified, and it helps you understand what that sound is about. So, or any of the things that I've described, or any of the chest conditions, just say, would you mind if I have a listen, and listen to both sides, back and front. I'm sure they won't mind you, but those sounds that you can hear are really important for you to be able to start to identify, because if you hear those sounds standing at the end or the side of somebody's bed, then you're worried. Sometimes you will only hear them through the stethoscope, sometimes you will hear them, but obviously they're amplified. And if somebody's got a chest infection, you may actually not hear air going into that part of the lung. I mean, do listen to it, listen when you're in, to yourself or colleagues. You can hear what normal inspiration, it's that take a deep breath that we all hear and hear said by doctors, but just make sure that you're not causing the patient any more respiratory distress by, asking them. Don't ask them to take deep breaths. Don't compromise their breathing anymore, but just say, could I just listen to your breathing? Go with the physiotherapist when they're doing this. The physiotherapists, when they see patients, will listen to their chest as part of their routine assessment. And the other thing you do is say, could I also have listening? The physiotherapist will help you be able to understand what you're hearing. Very useful thing to do, because those sounds are sounds that you've got to start to be able to recognise as triggers. Something's not right, something's wrong. So, adjuncts for assessment. Pulse oximetry. We've talked about pulse oximetry before. We've done pulse oximetry with you in the skills. You should be in your first placement. Many of you will have had the opportunity to use pulse oximetry. But again, have a look at the YouTube thing. It talks about what it's all about and in greater detail. Now, the other thing is peak flow recordings. Now, we've done some peak flow recordings with you as well to be able to estimate lung capacity. And again, you may have been working in areas where patients are required to do peak flow and you're required to record them. Spirometry is the next thing I'm going to identify, and again there's a little YouTube video explaining all about spirometry. The disappointing thing about doing webinars is that if I clicked into that link, it comes out of sync as a broadcast, and that is one of the shames, that we can't show you these and talk about what we see. If I was in a classroom, we would all watch it together and talk about it, but unfortunately the sync doesn't work at all with YouTube or any little videos. But spirometry is an important thing. It's a more in-depth diagnostic tool than peak flow. It looks at forced air capacity, so it looks at more measurements and more recordings of the lung function. So it's called a lung function test, spirometry. Again, if you work in a respiratory area, or if you're working with specialist nurses that do spirometry, ask them if you can have a go yourself, and you'll get to know what it feels like and what instructions the patients need to have, because it's quite a thing. They've got to breathe as hard as they can for as long as they can into the machine, and that gives a good indicator, and it is like the key tool for diagnosis when you're looking at long-term lung conditions. Very important tool to be used. Blood gas analysis, taking a sample to measure what the oxygenation, the carbon dioxide levels, the pH balances of the blood. This is taken from an artery. Some of you may have seen blood gases taken, arterial blood gases from the radial artery or the femoral artery. Blood sample taken, put in a machine, analyzes. This is a very clear diagnostic tool. When I spoke a little earlier about pulse oximetry, and if you've got peripheral cyanosis that it isn't always good and you don't have an accurate reading for pulse oximetry, and blood gas analysis is the key tool that will tell you exactly what's going on and able to analyse the body's ability for gaseous exchange, and looking at the oxygen levels and the carbon dioxide levels and the pH levels and see how things are circulating, because it's the only way to measure carbon dioxide levels, and carbon dioxide is toxic. The build-up of carbon dioxide means you'll stop breathing, it will knock off the respiratory centre, so you will see blood gas analysis being taken regularly in respiratory areas and intensive cares and things like that. The PowerPoint will be available at the end, and you can have a look through there. Someone's just asked about that. Now the other one that I've got on the list, exercise tolerant. Okay, tolerance, even exercise tolerance. An exercise tolerance test is where you will ask somebody to walk a few hundred yards, set walking limit, and during that period their pulse oximetry will be taken. They will have blood gases before and blood gases after, and what you're assessing is what effect walking has on their ability for gaseous exchange. This may be linked to assessment for somebody requiring to have oxygen therapy at home. And if a person, what we call desaturates when they take minimal exercise, then they're a candidate for requiring oxygen for their activities of daily living. These are special assessments that are undertaken in a respiratory clinic, but you will see that undertaken. You can look that one up as well. Key important thing is about evaluating the assessments that you undertake and documentation. Obviously on the patient observation chart following assessment, if you're assessing for the person's first time, rate, rhythm, depth determine if they're in their normal range, and therefore you've got what we call a baseline to go on. You can then compare the results to your baseline and information from your oximetry and the history of what's happening to the patient to look at them. So there's quite a range of observations that you can undertake and specialist tests as well as routine tests to give you an overall picture of the patient. So now I'm going to ask you another question or a poll. Just give me a second, I'll set that up. Oops. That's what I want to do. Just bear with me a second. So I've been describing assessing patients with breathing difficulties. What I want to ask you now is how many of you in your placements have had the opportunity to care for a patient with respiratory problems? Just wait a minute or two while that comes. It looks like an awful lot of you have, which is really good news. %71% of you have voted. Keep going. Just 1 or 2 minutes more. think we almost reached our limit there. No, we're still going. See if we can get it above 79%. Those of you that have nicked up for a cup of coffee, come back. Okay, we're there. So I'm going to stop that and share that with you. So 77% of you said that you have. So I'm hoping to move on now to talk about some of those problems a little bit more, and hoping that we can link in some of the things that I've been talking about already to add to it. For those of you that haven't, hoping this is going to prime you with a few thoughts and things. Okay, so I'm going to ask another question. How many of you have cared for patients with COPD, chronic obstructive pulmonary disease? Okay, so 68% of you have. Oops, I'm going to show that. Sorry. Yeah. So again, a fair few of you have. I'm going to talk about COPD. So those of you who have, we're hoping that you've had a look into this a little more. And so we move on. So I'm going to talk about both COPD and asthma. So when we get to the asthma, I'll ask the same question again. So we're going to look at COPD, chronic bronchitis as well, and we'll also be looking at asthma. So we'll move into that for the second part of the chat. Okay, I've talked about airflow obstruction before, and the key thing here is it's not reversible. So whatever you do, you can't improve totally their airflow. It's a progressive long-term disease. Once somebody has it, they have it for life. We talk about exacerbations. Exacerbations means a period of time when their breathing or the symptoms from their COPD are worse. This is usually related to getting a chest infection, but it isn't always. And their symptoms become worse from their normal day-to-day variations. So somebody with COPD will have breathing difficulties, and it will restrict their living. I'll talk a little bit more about that in a minute. So exacerbations are where they are worse. And the other thing about exacerbations is they will never, when treated, they will never recover to be how they were before the start of the exacerbation. So each time they have an exacerbation, they become progressively worse. So these figures, I checked again earlier this week. These figures were released in 2010. I find it quite curious that no review of these statistics has taken place. You will find information on the NICE website about COPD, but also the British Thoracic Society, and I'll talk about that in the end. I've got the references at the end. But I find it quite interesting that last year NICE guidelines were reviewed for the care of a patient with COPD, but they have not reviewed the statistics. So for me, 2010 5 years is quite a considerable and interesting period of time to have lapsed. So, whilst these figures are 2010, I think it's important to recognise that they're probably greatly increased. 3 million people, 90,000 people in the UK have the diagnosis. However, they reckon 2 million people have COPD, which remains undiagnosed. Partly, and they reckon mostly, is that diagnoses often don't take place until people are in their 50s. And one of the nice guidelines is for early assessment of people who are smokers, because I'm going to go on to say it is largely preventable and smoking is the cause of COPD. Okay? And therefore, nice guidelines recommend that anybody who's a smoker should have spirometry, which is the key diagnostic test, to identify, initial identification that a person has irreversible airway disease, irreversible damage to the alveoli. Okay, so smoking is the biggest risk factor. Now, most of us are very aware of smoking and cancer, but this smoking and COPD is not such a big public health risen issue over many years. And if you read about COPD, they talk about it as being the Cinderella disease because of the lack of investment by the government in producing guidelines in the past and looking at ways of tackling the issues and problems. And, you know, we could talk a lot about smoking, health, etc. Right, somebody's lost. Just a second, I think some of you have lost the screen. If you just bear with me. Ooh. Only a white screen. I'm not sure. I'm going to check a second. It was just a white screen. It's you should have a screen with writing on at the moment, guys. Hasn't been back since the poll. Okay, have I turned the poll off? I'll close the poll. Change the poll. Hide the poll. I've switched the poll off. Screen. Okay. I've clicked a few buttons. Yay! Okay, I'll go back a slide then. Phew. Right. I'm just going back a couple of slides. Thank you. Okay. Essentially what I've got on the slides that some of you haven't seen, or all of you haven't seen, is what I've been saying. And again, this will be available for you, so hopefully it'll be okay. And I hope, you know, hopefully you picked it up. I haven't gone too fast for you. This is the bit where I've given you those statistics. Okay. I've got a reference list at the end for these things that I'm referring to. Okay, so I'm back on the causes. Just going to have a little look. Okay, Anita's made some comments about, and I won't read them out because it is about her mother who passed away with COPD, but what Anita is saying is reiterating what I said about the lack of information out there. Yes, the presentation and the webinar are all going to be available. It takes about 10 minutes to record it, and then I'm going to get Caroline and I will put it up onto the site for you, so not to worry. Okay, Other risk factors other than smoking. Men are more likely to than women, but we do know from statistics on cancer, that lung cancer, that more recent than COPD is that more women are getting lung cancer now, and therefore because more women have been smoking from teenage years who are on their 60s and 70s now, and I guess we could question that there's probably an increase in COPD in women as well. Occupation, sometimes you have occupation breathing problems, you could as well, and they can contribute to it. So there are people who are working in areas where they're inhaling irritants will get fibrotic diseases which can also be linked to COPD. So people who've been down coal mines or working such as like China clay industry down in Cornwall, those are specifically linked diseases. Or also in the Midlands, people who work in factories where fabric is being made, there's lots of fine lint in the air from the weaving, inhaling that, making hats in the millinery industry, people who were doing that younger. In those days, the people who were in their 60s, 70s and 80s, those days, ventilation in factories wasn't particularly good, and we now know about the risks of mining, etc. But these things can all be contributing. Living in poor housing conditions, damp areas, climate change, living in areas where there's high pollution, and if people had problems as children with respiratory diseases. And there is some evidence of in utero exposure to smoking as well. Yeah, damp houses, asbestos. Passive smoking a risk? Yes, it is, and this is why smoking has been banned in public places. People certainly who were doing bar work, when they banned smoking in bars, and I know it's popular and not popular, but there is a link between them getting respiratory problems and potential long-term respiratory disorders as well, although it's smaller numbers. So yeah, there is quite a range, but never forget, smoking is the key there. For all of you that smoke, think about it. Okay, chronic bronchitis. Chronic obstructive pulmonary disease is divided into two things: chronic bronchitis and emphysema. Yeah, again, one of you has identified, Lisa has identified about her grandfather who had COPD. Yes, he smoked, and also he works in the China clay industry, so you've got a combination of, you're quite right, Lisa, a combination of factors. Do people with asthma have a risk of COPD? There is that as well. Asthma is classed as a lung disease on its own, but COPD can be linked. People who have COPD will often tell you that they have asthma, but that might be misdiagnosis. People have often been told, oh, you've got a touch of asthma. And a lot of people you talk to in their 60s say, oh, my doctor says I've got a touch of asthma, or I've got COPD, but there hasn't been any clear diagnostic tests. And spirometry is the gold standard test because it looks at air capacity. Blood gases will also contribute to that as well. So, chronic bronchitis, excess mucus secretion, and productive coughing. When the mucus production has been excessive for 3 months a year, for over 2 years. Chronic bronchitis is often prevalent again in people who have worked in damp areas, in mining, working with asbestos and all those kind of things as well. So again, it's that occupational thing. People who live in poor housing conditions. Everybody can get bronchitis and a chest infection bronchitis. When it becomes chronic, there are degenerative changes in the alveoli and degenerative changes in the bronchioles. Alveoli, the little air sacs of single cell thickness, it doesn't take much to damage and destroy them. Again, somebody saying that yeah, chronic bronchitis is these exacerbations and COPD. So COPD and chronic bronchitis go hand in hand. So COPD is chronic bronchitis and emphysema combined. Okay, and here we are, emphysema. So this is where the alveoli are damaged by smoking. The presence of smoke attacks the cells and damages the alveoli. There is a congenital disease where you get destruction of the alveoli, and alpha antitrypsin is the soapy solution that is secreted into the alveoli to increase the tension to keep the alveoli open. So if you're born without alpha antitrypsin, then your alveoli collapse and stick together and on themselves. But that's a blood test can diagnose that. Okay, somebody's asked me why can't people diagnose asthma in the under fives. I'm going to talk about that point when we get to the asthma section. So hold that thought. So what happens is you get gradual deterioration and air of alveoli, narrowing of airways, chronic bronchitis, that chest infection, floppy airways equals emphysema. I always describe it as, you know, when you let it blow up a balloon and let it down, it loses its elasticity and it just hangs floppily. Yeah, so you've got that mental picture, and that's what happens to the alveoli. Because when you breathe in, there is some tone in your alveoli and they expand. So if that elasticity is gone, then they don't expand to increase the capacity for gaseous exchange. So you get uneven ventilation between the alveoli. The more damaged they become, the more impaired gas is exchanged. And once combined, it's recognised as COPD. So the emphysema is the destruction from the smoking, and the chronic bronchitis are these chest infections. So we talk about things like smoker's cough. So the smoker's cough is due to the irritation of what's contained within the inhalation of the smoke, irritates and causes mucus production, and so you have this typical smoker's cough. And maybe a little bit of slowly creeping, increasing difficulty in breathing, and an increase in the cough. You may have periods where you get chest infections that move into becoming chronic bronchitis. Because it's slow and insidious, this is often why people do not get diagnosed until later on, when their breathing and their activities are compromised. And damage is irreversible. And so this is why you see what you see. So when does a smoker's cough and a little bit of breathlessness start to alert somebody that something's wrong? And generally speaking, it doesn't, because you slowly adapt and potentially reduce your activity or your ability to work. And if you look into the statistics, layers estimate a larger number of work days lost are attributed to COPD, people with the chronic chest infections, or the fact that they slowly become debilitated and slowly have to adjust their lifestyle to suit until they can find that their activities of daily living are compromised because they become breathless. Chronic bronchitis is permanently damaging, yes, because each time you have an exacerbation, each time you get an exacerbation of the bronchitis, the more damage is done, the more deterioration. So it's permanently damaging. It's a slow, insidious deterioration. So, what do we see? Laboured breathing. We've talked about laboured breathing, and I've described to you this morning already some of the signs. Breathless on mild exertion. So if somebody gets up to do something, maybe go out and make a cup of tea, they become breathless. Or go up the stairs, or go out shopping, they'll be breathless. What becomes a problem is when that breathlessness starts when they're at rest. They hardly need to do anything. And so this is what happens. People with COPD start to become reclusive, start to not be able to do activities of this, start to not to be able to go out, start to find that cooking exhausts them, simple cooking, so they eat convenience foods and become malnourished because it's difficult to cook or eat. It's very difficult to eat when you have difficulty in breathing, and so you don't eat very much. You might only eat things that are easy to prepare or easy to take out of the cupboard, and therefore you start not eating a healthy diet. And so malnutrition and COPD go hand in hand. We talk about cyanotic appearance, so that grey dusky colour. The weight loss is related to malnutrition. They have what's described as a barrel-shaped chest, and this is to do with hyperinflation. So if I've got difficulty in breathing, I will struggle to breathe in. I won't necessarily expire all the air, I'll just breathe in some more. And the intercostal muscles become stiff and fixed. The pursed lip breathing I described earlier. The hypoxemia, the high level of, reduced oxygen circulating. Hypercapnia, high level of carbon dioxide, high carbon dioxide is a new word, high carbon dioxide, hypercapnia, and the spirometry. Somebody's just asked me, does pneumonia cause permanent damage? Generally speaking, no. But it will cause damage to somebody who's got a chronic lung condition. So people can get exacerbations through infection, which I've talked about, but there can be times when they're non-infective and there are exacerbations. The non-infective causes are around panic attacks, so people get panicky when they're having problems breathing. You've got this response, the automatic response of the body is if there's difficulty, if there's a high creeping raise in CO2, is to breathe more quickly. Vagal stimulation, increase the respiratory rate. Release adrenaline to increase the heart rate, to pump blood round more quickly. So people will be tachycardic, breathing more quickly, and also, because of the release of adrenaline, you may start to get a little bit of panic attacks. If they've had previous experience of being acutely breathless and very ill, then it can influence how they psychologically can deal with being breathless. And panic attacks are often common and quite difficult to manage. Now, cold temperature. Now today it's cold and damp. Yesterday it was warm and it wasn't damp. Changes in fluctuation in temperature and weather can actually cause exacerbations, okay, because you're breathing in colder air, or it's damp, you're breathing in damp air. Then the other one is about air pollution as well. So, increasing work of breathing and difficulty in expectorating sputum. Exacerbations cause high mortality. I know 10 to 25% doesn't sound high, But if somebody's having exacerbation of their COPD, they're having increased difficulty, then there is a risk. And as I said, when you have an exacerbation, you never completely return to the lung function you were before, and so you're reducing their quality of life. Yeah. Julie, who has asthma, said with the exercise and cold, asthma is worse. The same thing with asthma, we'll talk about in a minute, Julie, is that seasonal change. This time of year, we're coming out of spring, and the same in autumn as well is tricky for COPD and asthma sufferers, because of the sort of one day it's all right, and the next day, one day you've got nice weather, the next day you haven't, and a change in fluctuation. So how can we help people with COPD? Okay, the first point there is all about it being irreversible, which is what I've identified before. Obviously, if somebody's smoking, you have to advise them to stop smoking. And we all hear the stories about, I was somebody who's 95, who smoked all their life and they're okay. Great, good on them. But 3 million people have got COPD, and it's 99% attributed to smoking. Having oxygen therapy can help, but oxygen therapy for exacerbations, so this is where you'll see people in hospital who symptoms have deteriorated and they require oxygen treatment because of their reduced capacity for gases exchange. Now, I mentioned bronchodilators earlier, and that's inhaled medications, so inhalers and nebulized drugs which can reduce the obstruction. In 2 out of 3 patients, obviously. Steroids. So the use of steroids to reduce the inflammation, the bronchial inflammation, because what happens in exacerbation, you get inflammation, increased mucus production equals obstruction. So taking steroids can reduce the inflammation, and you will find most people with COPD have had long-term treatment with steroids. At one time, people often were permanently on low doses of steroids, but you'll be meeting these people in older age because the side effects of steroids, the long-term side effects of steroids, it's been recognised now that short course of high dose reducing down is more effective. Problems with steroids for people with COPD is there's always the issue around unpleasant side effects, but what we look at things like is problems with skin, tissue viability, causes thin papery skin, which causes problems if you're not very mobile, and so you get all that kind of problems associated with that as well. Also, you get suppression of the own body's secretion of steroids as well, and a whole range of things. Now, severe exacerbations. Are steroids prednisolone? Yes. Okay. Somebody's identified something about aiming for identification of SATs. I'm going to talk to you about that in a second. Yeah. So, severe exacerbations may require what we call non-invasive ventilation or invasive ventilation. Non-invasive ventilation is where you force air in and oxygen into the lungs under pressure through a mask that is tightly fitted around the face. What you do by forcing the air in is you're pushing open the alveoli, and you may set the machine to ensure that the lung doesn't completely deflate, keeping the air passage open longer to improve gaseous exchange. Non-invasive ventilation. You may hear this called BiPAP. That is the name of the company that makes the materials. Invasive ventilation means intubation and intensive care. This is not often chosen because it is incredibly difficult to wean people off of ventilators with COPD, because they become used to the environment, the oxygenation environment that is created by the ventilator. But non-invasive ventilation you often see used in A&Es, medical admissions units and respiratory wards and treatment. Okay. With people with COPD, you will be treating them with oxygen therapy. What you need to do is, based on their blood gas results, 15% of people with COPD retain carbon dioxide. They never and survive and live on a higher level of carbon dioxide than you or I. Your respiratory drive is triggered by a drop in oxygen and a rise in CO2. These people, because they have a high level of CO2, their respiratory drive is based on a drop in oxygen, not a rise in CO2. So if when their oxygen levels drop, their respiratory centre stimulates. If you give them high flow oxygen, 100% oxygen, they'll stop breathing. We will return to this when we do year 2, when we talk about caring the critically ill patient. We'll return to this kind of why we don't give people with COPD high flow oxygen. But it needs to be carefully decided, because only 15% of people with COPD have retention, and therefore if you don't give them high flow oxygen, you could kill them anyway. So it's all based on blood gases. So we revisit this in greater detail in year 2. So again, 2010 figures, 5% of all deaths, 25,000 people a year. Maybe it doesn't say so much, but one person dies every 20 minutes. 80% is to do with smoking. 15% of patients with COPD die within 3 months after being admitted into hospital with an acute exacerbation. So we have to take acute exacerbations quite seriously. And some of that can be managed, better management. 800 million each year. Whoops, sorry about the spell typo. 24 million is lost in working days, which I talked about earlier. One in 3 admitted to hospital will come back again within 30 days, and of those 1 in 10 dies. And it counts for 1 million patient bed days per annum. So it is a high cost to the NHS, and certainly we hear of these term bed blockers used a lot, and people with COPD who are in hospital have often what is called sorry, I've lost my thread there. Talking about bed blocking, people with COPD have what we call revolving door syndrome. So a lot has been put in to looking at caring from the community. And those of you that have come across community matrons, and you will do in the course of your 3 years, part of the role of the community matron is to manage people with long-term conditions at home, and visit them at home and educate them at home. Part of the education is recognising subtle changes and deterioration so that they can start taking a course of antibiotics, a course of steroids, before they start becoming quite breathless and productive coughs. So we teach them about recognising those early signs, having the drugs at home ready to take. So this is what you'll hear about self-management. And we'll talk about self-management of asthma in similar ways. So it's recognising those subtle changes, taking the medication, getting reviewed by the doctor early or their community matron, and therefore starting the treatment and avoiding being admitted into hospital. We talked about the weather earlier. The Met Office, in association with the NHS, produce weather warnings specifically for people with respiratory disorders. And so they have a weather watch. People with COPD can be managed by telehealth, Have any of you been into somebody's home where they got a load of kit set up so they do their own do their blood pressure and it all gets through the internet? Do you want a show of hands? Do you know how to show your hands? Put your hands up. Anybody going to put their hands up? Anybody seen it in somebody's home? Yeah, quite a few of you. Great. That's good. So this is COPD patients. So again, monitoring of their vital signs and monitoring of their health gets fed in and they're monitored via telehealth and telemedicine. Quite an interesting thing. And the weather warnings, they get a phone call every morning telling them whether the weather is going to potentially adversely affect their health. So they could do that, or they can log in and look on the website. Lots of different ways in which they can. So again, they can check the weather. So they get today again as well. There's quite low cloud covering, which keeps in all the bugs and all the germs. So if there's a low cloud covering, they could be at risk. So it's like, don't go out of your home if the weather's going to be like this. All these weather warnings, very interesting things to look into. Again, as we develop you and talk a little more about chronic conditions, we'll revisit some of these things in the future. Now I'm looking at the time. We're okay for time. Okay, so pause there to ask you the last question I think I might have on there. And how many of you have cared for people with asthma? Ooh, more than COPD. I know inevitably when we talk to a group of people that somebody has asthma themselves, always. So some of you may have cared for people with asthma, some of you may have asthma yourself, and I'm hoping that you are relatively well as with your asthma. So, what is asthma about? Attacks of wheezing and breathlessness due to narrowing of the airways. It varies, and it can be reversed. The narrowing can spontaneously reverse, or treatment is required. Yeah. Okay. Thank you for reminding me to close the poll. Sorry, I'm looking at your questions and close. Right, back to the screen. Everybody see the screen? Yep, right, on we go. Okay. Oops, sorry, just go back and hold that for a second. So, intermittent airway obstruction. Now, somebody raised a question earlier about young people. So asthma is a disease that often starts in young life, but often people do develop asthma. Teenage times are another area, another period of life where asthma can start as well. Usually can be identified and linked to trigger factors, but quite often it takes a little while to work out what those things may be. And those of you asthmatics among you will almost certainly know what may trigger. Pollen and house dust mites. We've talked about changes in weather, and again now at this time of year it's the season of pollen, so again a high risk time for asthmatics. So what happens is you get mucosal inflamed mucosa as an allergic reaction and increased mucus secretion and bronchospasm. So the bronchioles go into spasm and the airway is narrowed. So intrinsic, so again, people are older, there isn't any allergy or family history, Could be related with chronic bronchitis, and this is why we often get a mixed diagnosis of asthma and COPD. It can be related to stress, and there is a stress and anxiety element in with asthma as well. It can be as a result of respiratory infection, and it could be linked to viral. Which antibiotics are appropriate? One of my colleagues in her late 40s has developed asthma over the past couple of years with and she's not a smoker. I guess get chronic bronchitis, and I wouldn't say she was a stressed person. It's sometimes one of those things, but she did have a series of sort of 3 chesty viral infections over a 6-month period, and they think it was related to that. So there you go. So just keep your questions open. So, any age then, mostly in youngsters, 10% of the under 10s are affected. I talked about puberty earlier, about teenage, and if you have asthma as a child, sometimes you will get, it will change when you go past puberty, which is quite a lucky thing. Middle-age asthma, more common in women. Just talking about my colleague there. 2,000 fatalities from asthma attacks each year. Those figures, sorry, I've gone mad now. Sorry about that, getting carried away. Those figures are 2012. So whatever is linked to the cause, it's about the way the air passages react. So we talked about the spasm of the smooth muscle. I talked about the edema, the mucous membrane, and the excessive mucous membrane production. What happens is you get excessive mucous membrane production, and it blocks the alveoli. It's called plugging of the alveoli. So it trickles down into the alveoli, and it blocks off an alveoli, and so you get airway obstruction. Okay, what do we do if somebody's having an acute exacerbation of asthma, so acute episode? Oxygen therapy, again, high flow oxygen, but arterial blood gases are monitored. Medication, I've talked already about these 2 agonists, and these are the inhalers and the nebulizers that we use that will relax the smooth muscle. Similarly, short courses of steroids, prednisolone again. Leukotriene is to do with reducing the inflammatory process, and these are tablets. Sometimes we use long-term anticholinergic, so it's to combat that allergic reaction of the muscle of the bronchial tree, and sometimes theophylline salmeterol. There are some new inhalers coming on the market at the moment. Some of you that are asthmatics may have started using, launched this year, which is a combination to replace the terbutaline and salmeterol, and there's some good results of that. So some of you may have done. It's only really, I went to a presentation 2 months ago. It's a combination inhaler, so long acting, and so it's a new generation replacing that, and they're looking at that being a change. So all the time, you know, same with anything else, there's new modern medicines being created for illnesses, and it's difficult to keep up sometimes. So what is the difference between COPD? It's irreversible, caused by smoking, later life, lots of symptoms and changes, the things that we've identified, and bronchodilators, the things that I've just been talking about, the inhalers and the nebulizers, don't often work particularly well. and there's high mortality rate. Asthma, reversible, caused by pollutants or stimuli, causing an allergic reaction, younger and older people. Breathlessness and wheezing, and if well managed, a low mortality rate. We'll talk about diagnosis. Oops, sorry, right, so I'm going to go back to that. With asthma, somebody asked me the question earlier is, why is it difficult to diagnose in the under 5s? It's really difficult for an under 5 to comply with the diagnostic test, the spirometry and the peak flow. And this is why it's difficult to say you have definitely got asthma. And generally what's speaking, they look at the symptoms and think about it and make some clinical decisions rather than based on tests. The testing's similar. The spirometry, the blood gases will give indications. This is why somebody asked me. The management is in many ways the same. It's regular checking. Those of you asthmatics should attend or have annual reviews, both COPD and asthma, annual reviews of medication, checking on your general well-being, health promotional advice, checking inhaler techniques, because inhaler technique is key, and we haven't in the past necessarily taught it well, and people don't often retain or have their inhaler technique checked. I'm not having to go at any of you people who have asthma, but it's well recorded, well known, and simply is about inhaler technique. Inhaler technique is key, because if you do good technique, then you can manage your condition, but also manage your exacerbation as well. And it stems back, for me, we had a patient admitted, a teenager who had moved locally into a college from up country, new environment, new home with unknown potential irritants, brought on an asthmatic attack. She had had mild asthma, never really needed much treatment, did have an inhaler, rarely used it, moved into a new area, started college, a little bit of anxiety potentially around that, moved into accommodation and triggered an asthmatic attack. We had her in hospital for 3 days, and the consultant came to see her and asked her to demonstrate how she uses her inhaler, and her technique wasn't very good. One is she hadn't necessarily been taught well, or it hadn't been checked, or it hadn't been checked that she knew how to use that. And he actually said to her, part of your problem is your technique. If your technique had been better, you may have avoided being admitted to hospital. And we were also very embarrassed that we hadn't actually checked her technique. And now it's a routine thing to check inhaler technique. I went to a respiratory conference where the respiratory nurse talked about this. This is going back maybe about 7 or 8 years. And they gave a lady an inhaler, talked to her about using the inhaler, didn't demonstrate it or didn't get checked that she could use it very well. The reason why she started having asthma is because of her dog, and she started becoming allergic to her dog hairs. She came back into the clinic 2 weeks later and said, I'm not getting any better, I'm still the same. And so they said, we'll check your inhaler technique. What have you been doing with your inhaler? And she had been squirting it over the dog. And I just re-emphasises why it's important to I can't labour that enough about the technique. The health promotion things is about identifying the pollutants and about avoiding what to do to minimise them. Again, the weather checking thing and being aware about pollen and what to do there, having low pollen pillows, the vacuum cleaners, the whole kind of caboodle around those things. Looking at the home circumstances, having tests to see. Sorry, I'm fading. That might be because my voice is beginning to go now. And so I'm just going to look at your questions here. Okay. Somebody's asked what hypercapnia is, and hypercapnia is high level of carbon dioxide circulating. Some people are having trouble with the screen, but I can't see any particular problem. Oh no, maybe not. Oh no, that was before. Sorry, I've gone back over the questions. Right. Yeah, I feel like I'm on a windy cliff. It is the room I'm in is very windy. Okay, I'm just about going to come to a close. I've given you an outline. This will be recorded, and I will put this in about half an hour. We'll get this up onto Centre. Has anybody got any last questions before we say goodbye? The last slide is the references. There is some information about oxygen therapy. It's a presentation which goes into a bit more detail, some of the questions you were asking and some of the things that I was talking about. The review, there's an article in the Journal of Advanced Nursing that is really good about nurses participating in their roles and responsibilities in caring for people with respiratory problems. And Jevon is another good one about examining patients, etc. And so the NICE guidelines is about deteriorating patients. I'm going to just add, before I post it, the 2014 NICE guidelines for management of COPD. I was looking at yesterday. I meant to put this on here yesterday, but I forgot, so I'm sorry. And also NICE guidelines for asthma, I'll add to that as well. And Asthma UK is another good. I'll add a few bits of extras. Right, and I've turned the screen back on. Actually, it's a good job I didn't necessarily have this on because I was so close to the microphone. You would have seen me coming and going. So I'm going to finish it at that point. Just checking to see if there are any more questions. Anybody wants me to answer? Okay, somebody's asked me about the new medication for COPD. I'll put the information about the new inhalers that are on the market for both asthma and COPD as well. That's fine. Somebody's asked me what brittle asthma means. It's a term that's been used in the past. It's rarely used these days, but it is still used. Brittle asthma means that a patient whose asthma is so easily triggered, so easily triggered, that then they deteriorate so quickly. It's called brittle asthma. Oh, that's nice. Somebody said that they get their asthma checked every year. Okay, folks, it's time for you to go off and have a bit of a break and me to have a cuppa. I'll finish this off, put some up-to-date references on there, get this onto the DLE for you later on this morning, and hopefully those of you that are feeling tired are now more looking forward to the weekend than you were at the start, and those of you that were looking forward to the weekend, I'm sure you're still looking forward to the weekend. We'll see you soon. I'm going to end this now.